Paul, are you ready as well? Okay, today, I will entertain questions before we start. And I'm going to reach over here and start our lecture capture, so those questions will be on there as well.
Mr. Baird, we do have a question to talk about, and then Mrs. Head is in here because she was supposed to talk about Oklahoma Health real quick too.
Okay? So go ahead and let Mrs. Head go first real quick.
So for all of colleges, I was wondering, is 2 or 3?
Okay, I can hear part of you. So
Okay.
your instructor might have to help me out or make sure extra mics are muted right now.
She wants to know what is the maximum flow rate of O2 that you would give a client who is diagnosed with COPD? Because she's heard conflicting answers and she wanted to get your response.
Okay, very good. All right, so I'm going to give you, I'm going to clarify something. Hypoxemia that is symptomatic, we're going to treat regardless of the patient being COPD or not. So if there's not a maximum, you can't give beyond this amount to a COPD patient. Remember we said we don't always know at what point in their disease process that their respiratory drive is going to flip. Okay, so we don't leave a person hypoxemic and in danger just because we're worried about their respiratory drive being oxygen driven. So the principle is we still treat the hypoxemia with symptoms with aggressive oxygen therapy. With that being said, recognize that if they have flipped and if you are giving too much oxygen, their respiratory rate will begin to slow and you'll have to respond to that. So as you do the evaluation step of the nursing process, you'll realize, whoops, I overstepped. And you simply turn off the oxygen or remove it for a few moments until they begin breathing at a normal rate again. All right, so that's kind of how you handle that. Now, as far as trying not to make that happen initially, then our standing order of 2 to 4 liters per nasal cannula still applies to those individuals as well. That's a good beginning point for somebody who is symptomatic. A physician may choose to write something less than that because of their history, but that's a provider decision. All right? Does that answer your question, or is that too vague?
That's good. Thank you.
Okay, you bet. Very good question. I'm glad you asked it. All right, other questions before we go further?
I have a question.
Okay, got one on this campus.
Well, let's remind you about this. Oh, snack.
About the smoking, about the 5-year history, yes. I forgot to mention when we were talking about smoking, I think there's another place that it comes up here today, but I'm going to mention it because my student did what I asked and I mentioned it for me. 5-year history is simply a way for us to objectify the potential damage to a person's lung from years of chronic smoking. 5-year history takes the number of packs per day they smoke currently, multiplied by the time of years that they have smoked. So they might be smoking 2 packs per day now for the last 20 years. So 2 times 20 would give them a 40 pack-year history. Now, why is that significant to us? Or let me give you another example. They might be only smoking 1 pack a day, but they smoked for 40 years. 1 times 40 is still a 40 pack-year history. Okay, so it's not merely the length of time, but it's the amount of damage that we're concerned with. And research has suggested that anybody who has a 20 pack-year history or greater will most often have COPD changes already occurring in their anatomy. Permanent changes that will affect their ability to ventilate. Okay, so somebody who's a heavy smoker will reach that point much faster. They'll get that 20-year mark much faster. Now, does that mean that somebody who doesn't have a 20-pack-year history does not have COPD? Not true. Anybody can develop it, and they'll develop it faster than 20-pack years if they have an AAT deficiency that we talked about. If they lack that enzyme to protect their lungs from those extra proteases, they will develop it sooner and faster than 20 years, even if they don't smoke at all, but are simply around the second-hand smoke. Those people will still develop it. Okay? All right, other questions?
Yes, we have one in.
Okay, go ahead.
On the medications, I know that some of them, we did talk about nursing implications, and some we didn't talk about many nursing implications.
Okay.
So are there any specific things that we need to remember as far as medications if we didn't talk about it? Should we go in the drug guide and If so, how can we distinguish which ones are the most important for a member?
Okay, I heard all of it until the last few words. The last few words kind of drifted off, but
If we
But
look,
let me address what I heard, all right? So nursing implications. There are two ways for you to learn those. One is, of course, to look them up in the drug guide or in your work guide if the instructor's provided them. The second way is look at that drug class and look at how it does its job. And so look at what its action is, look at what its therapeutic effect is, and think about if this drug had more effect than I wanted it to, what would be the side effects I've been watching for? And so a universal nursing implication is always monitoring for those side effects. Okay, so whether I say that or another instructor said that, that's always applicable. So if you're giving an antihypertensive and the therapeutic effects is going to lower the blood pressure, well, a side effect of all antihypertensives is hypotension. So a nursing implication is you're going to periodically check their blood pressure to make sure it doesn't drop below our normal range. Okay? So when we're talking about the respiratory meds, you can follow that same practice. So look at what it does, and then think about what did that mean for me as a nurse? And you will probably pick the most important ones. Now, there will be some more specifics that your drug guide may give, or I may mention, or Mrs. Haig or Mrs. Martinez. And when we do, that's because we pulled out what we want you to especially remember. But follow that other principle and you'll be fine. All right? Now, your in-class activity, if we get there, because we lost so much time on last Thursday, because it was 20 minutes, we lost some minutes to the test on Tuesday. I'm going to test that here in just a second for you. I can't guarantee we're going to get enough time in this day's class to get to that, all right? But you will be given that assignment, and you will be able to do it and return it on Tuesday if we do not get to finish it. Okay? And it deals with medication, all right? So that's what we're going to do is it'll be a study tool that you can use to help prepare. All right? Okay. Now, back to the test. From this point forward, your test, regardless of what the content is, you get 65 minutes to take your test in the computer lab. And then you get up to 15 minutes to review those incorrect answers that you selected. However, in order for us to have enough time to present content, from this point forward, lectures will always start at 1:45. Okay, so that will give you only 10 minutes to review. So most students don't take the full 65 minutes to test in the first place. So the vast majority of you may get here without any difficulty, but recognize lecture capture will be available if it records. If not, if you're concerned, then send your phone or something to record with somebody who routinely finishes faster than you do. Okay, so when they come to class, they can start the recording on your phone, and you'll have those first few minutes if the lecture capture is not working. All right? That's the only way we can come up with so that we can hopefully cover content. Okay. Question?
Assignment, we have a week to finish it.
With the in-class activity, we're going to try to finish it in class if we can.
But if not, it's due next Tuesday.
I said Tuesday, I meant Thursday.
Okay.
Mr. Berry gets so disappointed. I'm like the Dunkin' Donuts guy on the commercials years ago. I'm up there, even still out there, who literally meets himself coming and going. And so he was making the donuts over and over again. He saw himself coming out of the building and he was going. That's Mr. Berry. All right? Okay, so let's get started on today's material, all right? So I'm going to switch us back over to the computer because at some point, I don't know exactly when we lost our connection. So I'm gonna presume that we got through this slide unless somebody tells me otherwise. We got through the slide on page 140 that talks about our vaccinations. Is that correct? Did Enid and Talkwall get that material? Okay, I see Enid shaking their heads. Okay, so I'm gonna scroll through this one real fast then. All right. So we started this one. Did Enid and Talkwall get all of this slide?
no.
Okay, did we get through the peak flow?
Not the last sentence of peak flow.
Okay, so the last sentence under peak flow talks about the HEPA filter system. HEPA stands for high efficiency particulate air, high efficiency particulate air filter system. Basically, research has shown that those people who have asthma, if they will sleep with a HEPA filter in their sleeping area, so in their bedroom, it will help minimize the activation of their immune system, and so they often will have longer periods of stability in between those asthma attacks. Okay, so just cleaning the air that they sleep under can improve what they encounter throughout the daytime. Okay, so another thing we need to teach our patients is about how to use their inhalers and nebulizers correctly. And on page 570 and page 571, there are some excellent boxes, or charts rather, I think they call them charts, chart 37 and chart 30-8. Okay, one of them talks about using an aerosol inhaler and how to teach a client how to do it. And the other one talks about a dry powder inhaler. Recognize that only long-term patients typically have a nebulizer to work with at home. So again, we need to teach them how, not only how to use it, but how to clean it routinely, teaching them how to use a vinegar solution to disinfect so that they're not adding an infectious organism each time they take a breathing treatment into the airway, okay? And then we also want to teach them that if they're using a corticosteroid inhaler, that they need to rinse their mouth after they use it to minimize that risk of a thrush, and minimize that risk of candidus growing inside their mouth. Okay? All right. Now we're going to shift our focus from those chronic conditions that we've been talking about to an acute condition called pneumonia. Now those of you who have participated in SIMS, the second SIMS, have already gotten some of this material already in that context. So let's look at pneumonia from that perspective. Is what does it mean and how does it look different than a COPD? Pneumonia, by definition, is simply an inflammatory process that happens inside our lungs, regardless of the type of injury or organism that has caused that process to initiate. Remember, we talked about inflammation is consistent, regardless of what part of the body there is tissue damage. And so when it occurs in our lungs, there's a marked increase in how much fluid accumulates in the alveoli and around the alveoli. And we call that pneumonia. Is pneumonia a big thing? Well, recent statistics say that pneumonia and influenza together are the 6th and 7th leading cause of death. They're the second most common hospital-acquired infection, but they have the highest mortality rate. They are the leading infectious reason that people are admitted to the hospital in the first place. And then lastly, despite our use of antibiotics, the death rate from pneumonia in the United States has not improved in 50 years. People still die from pneumonia, especially the elderly and those who are immunocompromised. Is it important? I think so. So what are some things that can cause what are some things that can cause pneumonia? We call that etiology, or causes of that. Well, infectious agents, and I've listed the 5 most common ones, are certainly the ones that we presume that a patient has all the time they have pneumonia. But remember, there are other things that can cause it as well, including aspiration of these 3 things. So a client who has dysphagia or difficulty swallowing because they've had a stroke can potentially develop an aspiration pneumonia that may or may not have an infectious agent as part of that process. A patient who has drunk themselves to a stupor and passes out, and in the process they throw up, may aspirate their own vomit and have an aspiration pneumonia. A client who is under anesthesia for an emergency surgery, so they were not NPO prior to the surgery, might have nausea vomiting in relationship to the anesthesia and aspirate in the middle of the procedure. And then the third way is inhalation of toxic or caustic agents. So there are chemicals, there are things that we breathe, some that we can see, some that we can't, that can potentially injure the lining of our airway and set off an pneumonia process. But regardless of the nature of the injury, it still produces that same process in the lungs. So who are at risk for those things? Well, I've listed a whole slew of them there, and you might think, well, that just about covers everybody. And to a certain degree, you'd probably be right in making that statement. But I want you to look at this list and recognize that our immune system is not overly sensitive, meaning that it's going to respond according to its threat. And the reality is we can field off a lot of this for a long time. Typically what happens is when a patient has multiple risk factors is when they succumb to a pneumonia. First one we've talked about a lot because smoking, we've talked about what it does to the cilia. We talked about what it does to the protease levels in the lungs. We talked about what it does to the alveoli themselves. Advanced age. So as a person gets older, particularly the old, 65 and greater, they're at greater risk. Part of that has to do with chest wall compliance. Their chest is more stiff. Part of it has to do with a reduced tidal volume. They don't take as deep a breaths. And then part of it has to do with chronic illnesses that they developed as they've aged. And sometimes it even deals with skeletal changes like kyphosis, where they are starting to be hunch-shouldered, if you will, which compromises their ability to take those deep breaths. Upper respiratory infection. Those who develop an upper respiratory infection, something from the trachea up, are also at great risk for it finding its way into the lower respiratory tract, which is where pneumonia occurs. Those who are immobile. We've talked about immobility and fundamentals and some of the dangers it poses to our skin. But immobility also causes a tremendous amount of risk for someone to develop atelectasis as well as pneumonia. Those who are immunocompromised, either because they're on chemotherapy or because they have a disease like HIV or because they're severely malnourished because of tuberculosis infection or because of poverty or because of homelessness or because of alcoholism. Those who have a tube placed past their protection. Remember that airway is lined with mucus to catch invading organisms. So when we place a when we place a tube inside the trachea and inflate that cuff, our oral secretions accumulate around the top of that balloon. And if that collection of saliva and oral bacteria finds its way past that cuff, then it also can set off a pneumonia. So there are very specific things we do when somebody has been intubated to protect them from pneumonia. And there's even a special name, and Iggy talks about ventilator-acquired pneumonia, or VAP. Malnutrition, I mentioned, so there are multiple reasons why somebody might be malnourished. Dehydration adds to it because it makes those secretions more tenacious. Chronic diseases, so respiratory, like we've just been talking about, but even cardiovascular ones that lend themselves to pulmonary edema. Somebody with diabetes, we talked about their risk for infection and how their cardiovascular system is impaired, as well as their immuno system as well. Somebody with kidney issues can also be very prone to develop pneumonia. And lastly, cancer. Air pollution. All of us have countless, probably by the thousands if we could measure it, things that we inhale every day. But those people who can see their air obviously are inhaling more than we see or what we inhale. So those who live in big cities or have high levels of smog, or even those who live in rural areas with a lot of pesticides or dust being generated by the local farming communities. Anything that alters our level of consciousness puts a patient at risk, and several of those I've already mentioned, but recognizing disability doesn't always mean just a swallowing difficulty. If somebody else has to feed you or give you drink, there's always the risk of you being dehydrated and malnourished. There's always the risk of them feeding or giving you something faster than you can swallow, okay? Even if you have a normal ability to swallow. Residents in an institution, because of infectious agents very easily spread from person to person in close proximity, then that puts those people at risk as well. So that includes things like nursing homes, but it also includes things like prisons. And then lastly, the difficulty swallowing that I mentioned for an aspiration pneumonia. So what is actually happening that sets off a pneumonia process? Well, first off, there has to be something that produces that inflammation in those lower airways. Something is inhaled, be it organism or chemical or fumes, that sets off that process. Typically, that person who is at greatest risk may have a compromised cough or ciliary response, so a smoker would be an example of that. A person with COPD would be an example of that. Leads to that organism being able to take hold of and begin to multiply. We call that colonization. And then an infection develops locally in those alveoli. The fluid that rushes to the area as part of that inflammatory process brings white blood cells to the area. Your body, in an attempt to eliminate those things it's inhaling, increases its mucus production. And so the mucus, the organism, the white blood cells accumulate in those alveoli. The longer it stays there, just like something you set out on the cabinet, as air passes over a substance, what happens to the moisture content? It dries it out. It evaporates, right? The same thing happens inside a person's chest. And so what's left behind is what we call a consolidate, or a consolidation. In other words, the stuff that had been semi-liquid is now semi-solid, making it very difficult for that individual to clear it from their lungs. And so anything in the alveoli, be it solid, be it liquid, be it semi-ether, impairs our gas exchange. So what do we see when these people come to us? What are the things we are assessing for? So hallmark sign is fever, chills, and sweats, meaning that our body is responding to that threat. And we talked about that in the temperature lecture last fall. We talked about how the hypothalamus likes to keep our body temperature in a pretty narrow range. But when an infectious agent occurs in our body, it releases pyrogens. And our white blood cells, when it sees that somebody is in there that doesn't belong, it releases pyrogens. Pyrogens go to the hypothalamus and change the set point, causing our body to produce a higher, less desirable temperature for that bacteria or virus to live in, okay? So until the threat has been succumbed, then that body will keep that temperature in that range. Remember we said that typically the pattern of fever helps the physician identify whether that's a viral pneumonia or a bacterial pneumonia. Pleuritic chest pain. So remember we said the pleura, there were two layers of the pleura and there was pleural fluid in between that lubricated your lungs every time that you breathed. Somebody with pneumonia, sometimes because of inflammation, those surfaces touch. And so every time that person takes a breath, it hurts because it's like two surfaces touching each other that are not well lubricated anymore. And so there's friction that occurs and you can hear the sound, and we call that a pleural friction rub, but they feel the discomfort of that. Productive cough. And I'm gonna modify that one and say it may be productive or it may not be. If it's too thick for them to cough up, then it's a non-productive cough. If they're able to get it up, even if they don't ever spit it out, but they simply swallow it, we still call that a productive cough. If it comes out of their airway and is eliminated either in their GI tract or in their tissues or in their sputum specimen cup or whatever, that's still a productive cough. Hemoptysis. I think we're at Tonkwall. Tonkwall, what's hemoptysis?
Bloody sputum.
Bloody sputum. So this occurs as the organisms continue to eat the tissue locally. They might eat through capillaries. And as a result, blood trickles out into the alveoli, and if they're able to cough it up, the sputum is now bloody. We call that hemoptysis. Dyspnea, difficulty breathing or painful breathing, is often observed, not just pleurisy, but it just hurts. Headache. It's not uncommon for a patient with pneumonia to have a severe headache, just like someone with an influenza often has a headache. Fatigue. These people have no energy. They're overwhelmed with tiredness. They can't do what they normally do and just literally want to lay around and sleep if possible. Altered mental status or confusion and dehydration. Those often go together, and in an older adult, that may be our first warning sign that they're developing a pneumonia. So recognize that patients with dementia, you're going to talk about dementia starting on Thursday, patients with dementia, it might be difficult to recognize that they are more confused than they normally are without knowing their baseline. So somebody brought to the hospital by their son or daughter, and you don't know that that's their normal level of dysfunction, you might think that, oh, they've got to have an infectious process going on. So you need the family to validate, or you need the staff at the nursing home to validate, how does this compare, how does this cognitive function compare to what they routinely function? Diminished breath sounds, crackles or rhonchi. Remember, diminished breath sounds means there's less airflow through an area of the lungs. Okay, so diminished by itself is not a breath sound. It reflects the volume that you're able to auscultate based on airflow. So a person can have crackles and diminished breath sounds. They can have clear but diminished breath sounds, and that would be our emphysema patients. They could have rhonchi and still have diminished breath sounds. Basically, there's stuff in the airway that is changing their ability to ventilate. They often will breathe faster than normal and have difficulty breathing when lying down or lying close to flat. And we're not talking about the people who have orthopnea all the time. Their orthopnea is going to be more pronounced. We're talking about people who normally sleep flat in their bed, but now they can't. It's too difficult when they lay down. They panic. Now, interestingly enough, our body is very conservative in its use of energy. And so one of the things that happens when a person's in significant respiratory distress for any, prolonged point in time is our bowels take a slight vacation. Our body is going to focus on staying alive by breathing, and we're less concerned about making fecal material. And so many times a person who is severely distressed will have hypoactive bowel sounds. And then lastly, they may have, I think we're at Enid. Does that sentence up there say hypoxia or hypoxemia?
Hypoxemia.
Say it real loud for me.
Hypoxemia.
That is correct. And so our oxygen level in the blood is what we're measuring with our pulse ox, and that's hypoxemia. What we see in our tissues, we look at those signs and symptoms of ischemia that we talked about last fall, and that's hypoxia. So what could happen to these people if they don't receive good care? What could happen if they choose not to come and seek assistance with their acute infection or their acute inflammation? Well, they could develop respiratory failure. Remember, respiratory failure is not respiratory arrest. Respiratory failure means that they're not able to meet their oxygen and carbon dioxide gas exchange needs. And so their blood gases get all skewy. Their blood gases get skewy enough, and guess what? They can die. That's why that death rate has not changed in 50 years, because we still have people who suffer from pneumonia to the point of death. Pneumothorax, we talked about this briefly in the context of COPD. Recognize the people most apt to get a pneumothorax from pneumonia are those people who already have COPD in the first place. So their attempts to cough and clear that thick semi-solid sputum is what leads to them having a pneumothorax. A healthy person with healthy lungs probably would not develop a pneumothorax even if they had pneumonia. They'd feel like they were coughing their head off. Sometimes they'll even say, I feel like I'm coughing a lung up. And sometimes when they spit it in the sputum, you're wondering if they did too, but it's not, okay? It's really just the nasty that's been down there for a few days. Fractured rib. Just like our pneumothorax results from coughing fervently, people who are chronically malnourished or elderly often have very brittle bones. And so they can cough hard enough to fracture their own ribs spontaneously. No injury, just from coughing. And then lastly, I mentioned this briefly, I believe, that first or second day we talked. Remember when I said the main reason the person has inflammation is always to limit the damage to the area where it's perceived, and then it is to repair the tissues. That's our two primary purposes for inflammation to occur. So in this context, our body does not know if that inflammatory process is infectious or simply from something we inhaled or aspirated. And as a result, it's going to try to keep it contained right there in the lungs until it can eliminate any threat. Obviously, scrambled eggs or spaghetti down in your chest isn't going to spread into your bloodstream. But if it's bacteria or mycoplasma or fungus, it can. And if it does, if it gets past our inflammatory protections, then it gets into our bloodstream, and that organism can replicate wherever there's blood, which is throughout your whole body. And sepsis then becomes a life-threatening complication as well. All right? Okay, on your next slide, all of that was covered in your prep work, so please be sure and review that so that you have a good grasp of that content, because there could be questions over the test on those things. Let's move to pharmacology. And same way with the bronchoscopy, I covered this also out in the prep work as well. Okay. So let's go to pharmacology at the top of page 144. So I mentioned the other day that oxygen is viewed as a medication, even though it is inhaled. So recognize in the context of pneumonia, it may or may not be required. In other words, if a person is young and healthy and their lungs are young and healthy, first off, they may not succumb to pneumonia in the first place. But during periods of stress, sometimes they do. And some of you have, even in the last few weeks, succumbed to what sometimes a provider will call walking pneumonia. Okay? As a result, because of your body's ability, because your lungs are still basically healthy, those people typically don't drop their O2 sat low enough to require oxygen. But somebody who already runs low, so somebody with a COPD, typically when they get a pneumonia, their hypoxemia will be significant enough that we have to treat it. Okay? So the physician is going to base those decisions based on their hypoxemia. Bronchodilators, we mentioned in the context of COPD, they become relevant. Even if the patient doesn't use them routinely at home, they can help by promoting what? What do they help with, Stillwater? I think it's your question. Two things. What do they help with? Opening the airway. And so how's that going to benefit them? Okay, so it's going to improve some gas exchange. What's the other benefit?
It helps the mucus drain.
Well, it helps them be able to cough out that mucus. Okay, it's easier to cough through a bigger straw than it is a little straw.